Okay, we will be talking about tuberculosis. So, anyone is trying to say something? Okay, so we will be talking about National Tuberculosis Elimination Program. In this, now this is one of the health programs under uh, National Health Mission. So, why we have a separate program for TB? Because this is highly infectious and untreated TB patients can transmit this disease to multiple healthy persons in a year, and then those uh, persons who are staying with a TB case, they are at a risk to get tuberculosis from them. So there are multiple sign and symptoms of tuberculosis, which is cough for a long time, uh, cough with blood, patients getting chills, fever, chest pain, and fatigue. Now we will be talking about magnitude of disease in India. So tuberculosis is one of the leading causes of death among communicable diseases, and this is fifth leading cause of death among all diseases. So you can see this data is quoted from a global disease burden study which was done in 2019. Uh, estimated incidence rate of TB in India, this is 2019 data. 193 cases per lakh population, and estimated cases in TB in India in 2019 was approximately around 26.4 lakhs. Reported TB cases were 24 lakhs. In 2019, these reported TB cases decreased in 2020 to 18 lakhs, which might be attributed to TB, and then again until August 2021, this was 12.8 lakhs. So among HIV TB cases, there are further desegregation which has been done. So 33% of TB cases are staying in rural areas, 58% are in 33 in urban, 58 in rural, and 9% cases are from tribal areas. So primarily, men are more affected than women. So 62% cases are men, 38% are female, and 8% are children. Now, out of all these TB cases, 2% TB cases are HIV positive, 2.5 cases are DRTB, that is drug resistant TB, and then 65% cases are in between 15 to 45% of for 15 to 45 years of age group. So how National Tuberculosis Elimination Program came up? So in 1962, Government of India launched National TB Program, and then district TB centers were set up across all the districts. And then in 1993, WHO declares TB as a global disease. And then in year 1997, if you will see, Government of India has done a evaluation of National TB program. And then they realize that only 30% of the cases are being detected. And then out of those 30%, only 30% are treated successfully. So they felt need to revise this program, Hence, they came up with RNTCP. So RNTCP is nothing but Revised National Tuberculosis Control Program. So previously it was NTP, that is National TB Program. Now R was added and C was added. R because based on the learnings of previous program, this program has been revised and they were trying to control. So till 2000, till 1997, government was planning to control this. Now if you will see further, so now this is elimination. So now we are in elimination. Government is targeting to eliminate it, so that's why this became NTEP. So in 1997 this RNTCP came up, and then DOTS came into existence. So directly observed treatment short course program, so in which government recognized one DOTS provider, and DOTS provider used to ensure that the drug is consumed or taken in their presence by the patient. So that's what in nutshell it was all about DOTS. So initially it was rolled out in few districts on a pilot basis. In 2005 to 11, second phase was rolled out. So it was no, this program came into covered pan India coverage, and then the based upon the monitoring of this program, they improved quality and the scale up of services were taken. In 2012 to 17, government of India came up with a national strategic plan. So if you will see, most of the government health programs, they are having a strategic plan, whether it was malaria or whether it was leprosy. So they you will see that government is having a strategic plan which talks about how they are going to proceed further. So they came up with a national strategic plan in 2012 and 17, and then further it was again revised. So previously in first strategic plan, the focus was more on mandatory notification of TB cases, rapid molecular testing, active case finding, and integration of the program with national health mission. And the second national strategic program plan, which was launched in 2017. So this talks about patient-centric care for TB elimination. Now in 2020, Government of India revised RNTCP to National TB Elimination Program. As I said, that government is aspiring to eliminate TB now. And then 2021, government renamed this as TB Mukt Bharat Abhiyan. The program is same. This is just changing the nomenclature. So there are certain things which we should know about. Stop TB strategy, which came into existence in 2006, and this was basically announced by WHO, which was adopted by Government of India under RNTCP. And under this, they continue to provide DOTS and expanded as I said, this was uh, expanded to pan India, and then this was specifically addressing TB HIV cases, then TB and HIV cases like HIV cases who had this comorbidity conditions of TB along yes, and then addressing multi-drug resistant TB, integrating this program with existing health systems through health system strengthening, engaging private partners and alternative practitioners as well as private practitioners. So empowering patient, promoting research in field of diagnostic, treatment and vaccine. Focus came also on national airborne infection control guidelines and practical approach to lung health. Now, after stop TB strategy, in TB strategy came in 2014. So this is again, this was launched and approved by WHO in 2014. Because TB was still one of the deadliest infectious disease globally. So they came up with a strategy for 20 years. This is basically a 20-year program. So basically, they are mm, thinking in terms of mortality and morbidity reduced to zero because of TB. Sir, the interventions here are under this TB strategy are health related as well as social. Initially in the first class we had been talking, we had talked that there are multiple aspects when we are talking about health. This does not include only mm, medicinal, or there is a social aspect also to disease. So this in TB strategy covered those aspects also. So the stigma and the poverty aspect of this disease has been taken care of. So this strategy include patient-centered care and prevention, bold policies and patient support, intensified research and innovations were taken care under this. So we will be talking more in detail about National Strategic Plan. That is second strategic plan, which is still in existing, and this is supposed to be existing till 2025. So this was made for tuberculosis elimination by 2025. The major organizational changes under this national strategy were creation of a sub-district administration level. So if you will see previously history of TB in India, so you will see there is a STO at the district level, there is a DTO, which is district tuberculosis officer at a district level. Now under this strategic plan, they have envisaged, they have gone one step down, which is called as tuberculosis unit. So this is something which is existing at a block or a PHC level. And then they have envisaged, as I said previously, DTO was the in charge for whole district. And then below, if you will see, there was no one designated for TB, but because still this is one of the deadliest infectious disease, so government has thought of coming up with medical officer tuberculosis. So whichever tuberculosis unit has been identified by government, whether at PHC level or a block level, so that tuberculosis unit should have a mandatory medical officer tuberculosis. So that is something which has been invested under this program. Now the team of STS and STLS are under the administrative supervision of this medical officer tuberculosis control program and DTO. So previously, if you will see, the STS and STLS, they were under DTO. Now, can anyone tell me what is STS and what is STLS?
Sir, STS is Senior Treatment Supervisor, STLS is Senior TB Lab Supervisor.
Very good. So, since you have unmuted yourself, can you tell me whether you can see this government, because this program was envisaged and rolled out in 2017, this is a strategy plan. Can you see a tuberculosis unit at your place in your state?
Sir, TB units were there before 2017 as well. There's one DTC. There used to be one TB tuberculosis unit at the population of around 5 lakhs. Now it has been reduced to one TB unit at each 1.5 to 2.5. That is on an average of 2 lakhs. There is a one TB unit, but in hilly or desert or some hard to reach areas, it can be even at 1 lakh. But usually it is at around 2 lakh population, and now they have decentralized it to block level. Every block that is developmental block needs to have a TB unit.
So
That's how they have designed the program in the coming years.
that is what I am asking. So previously, if you will see, still in some of the states, okay, this envisaged the structure has not happened. The so-called tuberculosis unit decentralization at block level has not reached up. So you are what I understood from you that you are saying that in your state you can see a tuberculosis unit down to district also, right?
Yes, I've worked in 3 states: Uttarakhand, UP, and MP. In all these states, it has been decentralized to block level.
Good. So that is so because TV program itself is comes with a lot of responsibility and a lot of financial power. So this centralization has been basically done to ensure that the things are being taken care. So I am assuming this was Vikas who was responding to my question, right?
Yes, sir. Yes, sir. Yes, sir. It's me, sir. Thank you, sir.
So anyone from Northeast, what is situation in your state? No one is willing to unmute and say.
So I've worked in for some time in Northeast as well. So in
No,
Meghalaya, I've seen DTO, and then there's used to be an MOTC as well. In Meghalaya, I mean, there's a DTC, there's a MOTC as well.
DTO is a mandatory position that is definitely in existence throughout India.
Yes, sir, it is a mandatory.
I would love to hear first-hand experience. We have multiple students from Northeast.
Yeah.
No one is Harris. Can you unmute yourself?
Sir, good morning, sir. Sir, since I'm not directly involved in the TV program, I'm not able to comment much on the TV program, sir.
But if I'm right, you are a program of the system. You are part of the system, not with TV, with something.
Yes, I am the ASA program manager.
Okay.
ASA program, State Community Process Program.
ASA program at a state level.
State level, sir. But I'm not very much involved with the TV program, so I'm not in a position to comment on it, sir.
Okay. What is your designation?
State Community Process Program Manager.
Okay. So DCMs, all DCMs, you are taking care.
Yes, sir. Yes, sir.
And how many districts are there in your state?
16 districts, sir.
Okay. And you people have completed all the ASA modules.
Yes, sir. We have completed, and we have started the extended packages as well. We have finished the TOT for that, and we will be rolling out for the ASA training.
So sorry, I'm little diverting from my topic because I have been part associated with ASA program. That's why I'm trying to understand.
Okay, sir.
Quick things. So how you are doing ASA payment? Is it online or still with the?
Yeah, it is online, but as of now, we are doing it through the primary health centers. But this time in the ROP, we have proposed an ASA software wherein we can, pay the ASAs directly through the software, through the portal.
So you will be developing this software?
Yes, like the states of Assam and Meghalaya has.
Okay, that is what I am saying. Some of the states they have very good software.
Yes,
so,
that is true.
Which is basically NIC is the owner of those software, so you don't have to pay anything. So
there is a maintenance fee, sir. There is a development fee as well as maintenance fee.
NIC will see.
No. NIC does not do anything regarding this. We have to develop it and maintain it on our own. It is just that they are supporting the portal through in terms of internet connectivity.
See, I'm giving you the background. Okay, this background comes from Bihar.
Okay.
So there is a software called, if I'm right, not Anmol.
Anmol, sir. Anmol.
No. Anmol is government application.
ANM online, yeah.
Okay. So this is some. Let me find out. So Ashwin portal. Okay.
Ashwin. Okay.
ASHWIN. So this has been developed by one of the development partner. supported
sir.
by Bill and Melinda Gates Foundation. Okay.
Okay. That must be a long time back then.
No. Government. Bill and Melinda Gates is still supporting government of Bihar for your information.
Okay.
But this application is 4-5 years old. Okay.
Okay.
And I can see this is working seamlessly without any problem over here in Bihar. This is being
Okay.
so because this is something which can be replicated. I don't think there is something which you need to purchase once again or reinvent the wheel. So
Okay.
if you people have a look and see if this can be rolled out,
Replicated.
yeah, replicated over there.
Yeah,
Because
but sir, we have already proposed in a PIP, and it's in a position of being approved right now.
but
So
it will take some developing time, right? Once
yeah,
the application,
at the most 4 5 months, sir, for
yeah,
Manipur.
application. How many districts are over there?
16 districts.
And how many ASAs altogether?
Uh, plus minus 4,000 something. Sir.
Okay, and what is the condition of HBYC rollout in your state?
HPYC is it is being rolled out, but the procurement of the HPYC items are in process right now.
And
So
anyone is supporting HBYC over there?
yes, child health nodal officer is supporting the HPYC.
Any development partner?
Development partners, I'm not very much aware of it, but I think UNICEF, not UNICEF, yeah, I think UNICEF is in touch with his child health nodal officer.
Mhm. Okay. So sorry to others because we diverted. Okay, thank you, Harris.
Okay, sir.
So, in the national strategy plan, as I discussed, that they have investors to come up with tuberculosis unit, which is below district level, at certain places at block level and at certain places at PHC level. And there should be a designated medical officer tuberculosis control at those places, and then team of STS and STLS should be under the administrative supervision of if there is a medical officer tuberculosis, he will supervise, otherwise it will be the DTU. And they have also envisaged of no PHI. So peripheral health institute is a health facility which they have talked about in tuberculosis program, and they should have at least one medical officer who should be ensuring that the drugs are being prescribed to those patients. So even the private clinic and NGO participation in these private clinics or private registered practitioners, and then at some places there are NGOs who are running those clinics. So they are also if under NTEP registered in those areas, then they will be considered as peripheral health institutes. And then some of these PHCs are also functioning as designated microscopy centers. So PHI has been given a responsibility of case finding and case management. And if there is less than one medical officer posted in a PHI, one is to be identified. Okay. If there is more than one medical officer posted in a PHI, then one is supposed to be identified for responsibilities of NTEP and referral for screening for uh, uh, diabetes mellitus will be responsibility of the peripheral health institute, whereas TB diagnosis is initiated. And diabetic TB patients has to be if there is any patient who is having diabetes along with TB, they have to be linked with uh, diabetes mellitus care. So the key services which are identified under these are pre-diagnostic and treatment for the TB patients. That is public health actions which are identified are contact tracing. I'm not going to talk about that. We have already discussed multiple times what is contact tracing. testing for comorbidities, because these patients are mostly immunocompromised. So certain at times what happens, the patient has gone for HIV, then you will come to know that they are having TB, and certain at times it happens vice versa. TB patients are identified as HIV patient. Similarly, these TB patients multiple times are supposed to have diabetes mellitus, or patient is having diabetes mellitus, and then you came to know that they are suffering from TB also. So there is because in TB, drug is being given for a longer time, so there should be a treatment there in support. And there is something called Nikshay Poshan Yojana, which we'll be talking in detail under this. Basically, this is all about providing nutritional support to the patient and then the preventive measures. So there are basically 4 aspects under this national strategic plan. So detect, treat, build, and prevent. So first is to find all TB cases with an emphasis on reaching every TB patient, even in the private sector. Treating all the TB cases with high quality anti-TB drugs, which is being provided free of cost by government if they are not following that regimen, because of which we are landing up in multiple drug resistant TB. And now most of the cases which are reaching to the government sector are MDR TBs. So preventing the emergence of TB susceptible population and stop catastrophic expenditure due to TB by all, and build and strengthen supportive ecosystems, including enabling policies. This is something which is always written but never happened. So detect. So there should be decentralized TB screening to Ayushman Bharat Health and Wellness Centers. Can anyone tell what SWC is now known by?
आयुष्मान आरोग्य मंदिर.
हाँ, आरोग्य मंदिर हो गया, वहाँ हम लोग पूजा करने जाएंगे, है ना?
हाँ सर, एक्चुअली नाउ देव वो अब रीनेम कर दिया है उसको, और वहां पर लिखा भी जरूरी है. एंड दे आर मॉनिटरिंग इट ऑल्सो. ये जो अभी नया अभियान चल रहा है, विकसित भारत संकल्प अभियान, उसके अंदर देयर इज अ क्वेश्चन ऑल्सो कि हैव HWCs बीइंग रीनेम्ड एज आयुष्मान आरोग्य मंदिर.
And what if it is not renamed?
वो सर उसको नो है, उनकी मॉनिटरिंग का वो है, अभी अभी चल रहा है, 26 जनवरी तक चलेगा. So there'll be some doing some action on that, because इसके लिए उन्होंने जियो निकाल दिया है कि इसको आयुष्मान आरोग्य मंदिर की तरह नामित करें.
Again, I am diverting from the topic, but being public health person, you should always have those debates. उन्होंने जियो तो निकाल दिया है, लेकिन उन स्टेट का क्या करेंगे जहां बीजेपी की गवर्नमेंट है?
हाँ सर, वहाँ वहाँ नहीं, नहीं भी होगा, ठीक है, they'll be putting some administrative pressure.
Some of the states, they have bluntly said we will not do that.
हाँ होगा ना सर, होगा.
There is something called PAVIM. There is something called 15th Finance Commission. These all are sponsored by Government of India. इन्होंने बहुत सारे स्टेट ने लेने से मना कर दिया. उन्होंने कहा हमारे क्या है, we will take care of these things under NHM fund. We don't need extra funds. तो अब उसको आरोग्य मंदिर बनाइए या आरोग्य मस्जिद बनाइए. See, basically these things, I personally feel, I might be biased also, looks like that these are all election time. So visibility लोगों को चाहिए, everyone is counting on that. So being a public health person, we should be very unbiased when we are looking at things. SWC has reached out, district से भी बहुत, PSC से भी नीचे वाला ये SWC है. तो कितनी SWC है, सोच लो ब्रांडिंग से कितना विजिबिलिटी मिलने वाला है. So that is
बहुत.
So anyway, our focus is that the TB screening has been decentralized to even health and wellness centers. Molecular scale up molecular diagnostic to the peripheral levels, early detection of drug resistant TB, vulnerability mapping and active case finding, and then engagement of private sector in this. So there are the figures over there. Testing done through microscopy, testing through rapid molecular test, cultural lab. Now there are multiple options by which people can test TB. So the old standard was microscopy or X-ray. Now there is TrueNat, and CBNet. So these are higher versions of testing. Certain at times when people do suspect and then they think that these states are not going to come under microscopy. Microscopy and X-ray, these are basically cheaper, and these are done for a larger mass. So so people are screened through that, and then those who are still suspected but they are not finding, so a few of them they go to CVNet and to TrueNet. Again, that is not a part of discussion over here. So, but you
सर
should.
अब तो अपफ्रंट कर दिया है सर. अब
हाँ जी.
नाउ दे हैव डिसाइडेड दैट ब्लॉक लेवल जो टेस्टिंग है और जितना भी ज्यादा डिसेंट्रलाइज कर सकें, देयर बी नाउ देयर इज अ पॉलिसी ऑफ अपफ्रंट मॉलिक्यूलर टेस्टिंग.
So they are directly going without microscopy to molecular
Yes, sir.
testing.
Wherever the machine is, wherever there is a CBNet or TrueNet,
अरे भाई,
they'll first be subjected to these. And if there is not, then they may be subjected to microscopy, or if there is a nearest place where they can be subjected to this TrueNet or CBNet, and the sample would be transported there.
issue is like states like MP, Rajasthan, Bihar, UP, do they have CBNet and TrueNet at district levels?
So
Because
they have TrueNet and CBNet at block levels also.
in MP, Rajasthan.
Yes, it is there, sir.
Okay.
And we are trying to decentralize it to further down, but then presently we have all blocks have at least either TrueNet or CBNet.
So currently for past 2 years, I am based in UP and Bihar. So as per my understanding, these two states, they are going towards no district saturation, but still there are certain places जहाँ पे district पे नहीं है, because वहाँ पे medical college में है. So hopefully then we are on the right path and then we will achieve that. So treatment, as I said, that there is a defined treatment dose, and it's a longer 6 months, 9 months. So they are aspiring to sustain this treatment and with a success rate of 90%. And we don't have a injection for this treatment, so injection-free treatment regimen. And then if there is a addition or newer addition of drug, so to scale up those newer regimens. So to prevent this was launched during COVID. So sustaining COVID appropriate behavior, we are still having those COVID cases coming up. So contact tracing and TB preventive treatment, airborne infection control in community and health facilities, and community mobilization and people movement. So one of the aspect was built. So under these, how they are going to build upon strengthening this further. So through IEC, through capacity building involving more trained human resource, multi-sectoral collaboration, digital intervention. So by improving surveillance and then focusing on procurement and supply chain management. So this strategic plan talks about community engagement, multi-sectoral responses, active case finding, TB comorbidities, private sector engagement, drug-resistant TB, DCT tools for adherence and monitoring, preventive measures. So this is how the organizational structure under ministry. There is a central TB division which takes care of this TB program. So there are national committees, state TB cell, and national institutes. These national institutes basically are research institute or academias who are pioneer in their field. And then under state TB cell, there is district TB centers, and then there is TB unit which I talked about, and then there is TDC, that is TB diagnostic centers, and then comes under peripheral health institute, and down to that there is health and wellness center. So मृत्युंजय, मैं तुम्हें कॉल करता हूँ 5 मिनट 10 मिनट. क्या बोल रहे हो, क्या बोला? So there are other supporting facilities under this structure. So there is NRL, which is National Reference Labs. So these are 16 numbers. So there is NRL, there is IRL. IRL is Intermediate Reference Laboratories, and there is Culture and DST laboratories, which are 81 in numbers, including IRL, NRL, and there are CVNet laboratories. So I have talked about in briefly NICSA. NICSA is, as I said, that this is towards taking care of the nutritional need of the patient. So 500 per month is given to every TB patient through DBT. So they will be transferred these. They will not be given anything in cash. So they will be transferred this money to their account. So this scheme was rolled out in April 2018, and this whole budget is somewhere incurred over. This is 1204 crore, 1204 crore रुपए खर्च हो रहे हैं. So all those who are working with the system, they are aware what is PFMS, right?
Yes, sir.
PFMS का full form बता दीजिए. कुछ बच्चे ऐसे भी हैं.
Public Financial Management System.
Very good. So this is basically a system where wherein government transfers money to the beneficiary, and not only beneficiary, even their transaction happens through PFMS. So because these patients, they are nutritionally compromised. So certain states before this NICSA Yojana, certain states has taken initiative. They were providing egg, banana or milk. वो जहाँ से वो ड्रग लेते थे, जहाँ भी उनका जो सेंटर था, टीबी सेंटर, जहाँ from wherever they were taking drugs. So they had identified a vendor, and that vendor was supposed to provide egg or milk. So they used to give. So based upon those learning, this was incorporated, and now they were given money. Previously, it was that they used to get those nutritious item. Now they are being given money. So providing food was always better. We used to ensure that they were getting food.
So now additionally, they are giving food baskets, nutritional food baskets as well under the Pradhan Mantri TB Mukt Bharat Abhiyan through by linking them with Nikshay Mitra. I mean, the one who will adopt that patient and who will take the responsibility of providing nutritional food basket every month for 6 months.
And
so additionally, it is being given under the PMTB MBA.
And what is under those basket?
Sir, there are so many nutritious things. They were given 3 different categories. I mean, 3 different types of food baskets. This some dal is there. The same nutritious thing. I mean, the one which can stay there in the house for long. I mean, not which is going to decay in a short span of time.
And this is through government or through some vendors?
Sir, it is actually we have to make Nikshay Mitras on voluntary basis. Then we link the Nikshay Mitra with particular TB patients, and anyone can become Nikshay Mitra through that portal, and the person can support a TB patient in any geography of India. That is the thing. And that's purely voluntary. Purely voluntary. Additionally, we are trying to take support from this CSR funds, corporate social responsibility. These big organizations which have to shell out some, I don't know, 2% or 5% of their annual turnover. They are also coming out, not in a big way, but the ones who have come, they've given a lot of money in particular district for a period of 6 months or 3 years, like that.
My question is still unanswered.
Yeah.
Under Nikshay Mitra, you are saying they are TB patients are being provided food basket, right?
Yes.
So who is taking care cost of that food basket? Government?
No, government is not paying that thing. I
So
told you, the fund is either through CSR fund or people are donating fund to some particular account called Red Cross. Some people are many a times it is not even a fund. I mean, it is individual case to case basis. One person can give to 6 people, 1 people, but we are managing. It is being managed through DTC, district TV cell only.
This is what I was trying to do. So this
Yeah.
is thought of, okay, but there is no structure. There are certain states where they are getting CSR fund or many volunteers, they are giving that food basket. Now there are states where they are hardly bothered or they thought of giving that. So वहाँ पे निक्षा मित्र हैं, वो टीबी का दवा खिलवा दे रहे हैं, बाकी चीज कर दे रहे हैं, लेकिन ये फूड बास्केट नहीं है. Okay, so because there is a cost behind that, and if you are thinking of covering that cost for 6 months, so that will again in multiple population that will increase. Where you are posted currently?
Sir, MP.
MP, and which program you are taking care?
NTP only, sir.
So you are, भाई तुम ही class ले लेते. I think you would have taken it better, right?
थैंक यू सर, थैंक यू. नहीं सर, आपका बहुत स्ट्रक्चर्ड है सर, क्योंकि आपका ऑल ओवर इंडिया का व्यू है इसमें.
So you are placed in Bhopal.
Yes, sir. I look after Gwalior Chambal division, 8 districts, plus I am the headquarter consultant for MP, based at Bhopal also.
So where
I
you
look after, I have dual responsibility here.
where you are based in?
Gwalior and Bhopal, both. Right now I'm in Bhopal, but I have to take care of Gwalior districts as well. So
What is your
I'm the state headquarter consultant, WHO and TP.
So you are placed by WHO.
Yeah.
Okay. वहाँ पे ग्वालियर में डॉक्टर गौड़ है मेडिकल कॉलेज में.
हाँ, pediatrician.
HOD pediatrics. Yes.
He's a pediatrician. Yeah.
He is one of my.
और भोपाल में भी there is one Dr. God. He's HOD. He used to be HOD PSM. He's Dr. देवेंद्र गौड़. ग्वालियर में वो pediatrician हैं.
भोपाल में डॉक्टर भंबल हुआ करती थी.
Pardon sir?
डॉक्टर भंबल.
अच्छा, मेरे को नहीं आइडिया.
लेडी डॉक्टर, वो काफी पहले रिटायर कर गई. ये 6-7 साल.
अच्छा.
6-7 साल पुराना था.
जी सर.
चलो कोई नहीं. तो अभी वी आर टॉकिंग अबाउट, हाँ, तो यहाँ पे 3 tier लेबोरेटरी सिस्टम है. पेरिफेरल लेबोरेटरीज है. उसके बाद देयर आर SRL, IRL, which I talked about, and initially if you remember I have talked about central level institute. So central level labs are there which are known as NRL. So peripheral labs, SRL, IRL and NRL. So that's how it goes. This tiering system for laboratories are over there. And let me tell you, this whole laboratory system of TB is a little different from existing TB, existing laboratory system. But going ahead, government of India is envisaging to have only one laboratory at a health facility. So if you people are free and interested, you can go and always read about integrated public health laboratories, IPHL guideline. So what government is thinking of, vector borne का जो laboratory होगा, AIDS, TB, or for that matter urine, blood, whatever, CVC, whatever test you think of, the sample will be collected in only one lab. It will be tested only under one roof, and going ahead they will be connected to laboratory information management system, where everything will be barcoded and then the report will be sent to patient on their mobile phone. This is a distant dream, but still certain places things are happening, and hopefully in coming another a couple of years we can see some of the states showing these role models. If I am right, in Chhattisgarh we can see some of these master of art laboratories currently. इसमें जो की एक्टिविटीज जो इन्वेस्टर्स की गई है नेशनल स्ट्रेटेजिक प्लान में, So those are active TB cases finding, newer and shorter regimen. There are different regimen for different type of TB cases. The private sector engagement, and then financial and nutritional support to the TB patients, and then again these all monitoring and things are happening. I wish I would have added some of the dashboards. So I think those because you would have seen you are aware of the dashboard, national dashboard, state level dashboard, which shows how many cases, right?
Yes, sir. We have that this Nikshay case based software. उसमें सर डैशबोर्ड है. एडिशनली few states मतलब मेरे को लगता है सभी में होगा. स्टेट NHM डैशबोर्ड भी है.
सारे
But
state,
then
I'm talking about state dashboards only, NHM dashboard. So
जी
this
सर.
is something which shows that how technology has अगर आज से 5 साल 10 साल पहले बात करते तो ये सब डिस्टेंट ड्रीम लगता था गवर्नमेंट को, एंड दे यूज्ड टू थिंक कि दिस इज ओनली व्हिच इज समथिंग डेवलपमेंट पार्टनर्स के पैसे से होगा, इंटरनेशनल ऑर्गेनाइजेशंस कर पाएंगे. बट of lately government has invested a lot on TV, and thanks to global fund they have also invested a lot of money in TV in India, and because of which we can see all these things in action. And then last slide but not the least, TV हारेगा देश जीतेगा. तो ये भी हमारे प्रधानमंत्री जी की देन है, टीवी हराएंगे और देश को जिताएंगे. So this was all about in nutshell about TV. I need to go and see that still कुछ टॉपिक बचा है या मेरा टॉपिक शायद खत्म हो गया. किसी के कोई सवाल है? Anyone is having any question?